This audio presentation was pre-recorded and edited for brevity and clarity.
Hello and welcome. My name is Dr. Jimmy Liu, and I'm the new Director of Vision Science Programs at BrightFocus Foundation. I'm pleased to be your host today for today's Macular Chat, Saving Sight, How Long-Term Treatment Helps Slow Geographic Atrophy. Macular Chats are a monthly program supported in part by sponsorship from Apellis, Genentech, and Regeneron, designed to provide people living with macular degeneration and the family and friends who support them with information straight from the experts. The information provided in this program is for educational purposes only and should not be considered medical advice. Always consult a qualified healthcare professional regarding any medical concerns or conditions. Please note that BrightFocus does not endorse or promote any specific brand or product. BrightFocus Foundation's Macular Degeneration Research Program has supported over $56 million worth in scientific grants exploring the root causes and potential prevention, treatment, and cure of macular degeneration, and is currently investing in 44 active projects across the globe. Now, I would like to introduce today's guest speaker. Dr. Sara Fard is a board-certified ophthalmologist specializing in vitreoretinal surgery. Born in Iran and raised in Toronto, Canada, Dr. Fard's academic and personal journey reflects a lifelong commitment to excellence, compassion, and service. She completed her undergraduate studies at the University of Toronto and earned her medical degree from the University of Maryland School of Medicine. It was during medical school that she discovered her passion for ophthalmology. Drawn to the profound impact of restoring vision and the precision required for ocular microsurgery. Known for her calm demeanor, attention to detail, and genuine empathy, Dr. Fard combines her deep clinical knowledge with a patient-centered approach. Her specific passions in retina include diabetic retinopathies and our topic today, age-related macular degeneration, in both their treatment and prevention. Thank you for joining us today, Dr. Fard.
Thank you, Jimmy. Thank you for that wonderful introduction, and it's a pleasure to be joining you today.
Of course, and it's so great for you to be on this call and pleasure to speak with you today too. So let's jump right into the questions. So the first question that I have is, for those that are unfamiliar, can you explain what geographic atrophy is and how it fits within the spectrum of age-related macular degeneration?
Yes, absolutely. And thank you to all our participants for joining us today. So geographic atrophy, as sometimes I'll just say GA, is the advanced stage of non-exudative or dry age-related macular degeneration and consists of localized, well-demarcated loss of outer retinal layers and its underlying layers that may expand over time. Geographic atrophy is the final stage of dry age-related macular degeneration.
Perfect. And so when you diagnose geographic atrophy or GA, what signs should individuals look out for?
Geographic atrophy is diagnosed via clinical examination that shows atrophy or sort of loss of cellular layers in the retina. We can confirm it in the clinic with imaging of the retina. Individuals should look out for blind spots in their vision, which will usually be near their central vision, as well as difficulty seeing at night and with reading.
Nice. So just to kind of recap, the retina, which are the important cells that help translate what you see into information your brain can understand from your eye, start to die or atrophy when someone has geographic atrophy, and which affects your ability to see centrally. And the only way to confirm if you have geographic atrophy is through retinal imaging through your healthcare provider.
Exactly. Thank you, Jimmy, for clarifying and simplifying. Exactly. This is retinal imaging as well as with the retinal exam, which your ophthalmologist basically puts on a headset and takes a look at your retina with a lens.
Perfect. And so another question that I have is, GA was long considered untreatable. What breakthroughs led to the development of current therapies?
A great question. Basically, research into its pathology and genetics have found that geographic atrophy involves dysregulation of a certain pathway in the immune system. This pathway is called the complement pathway. Therefore, we've had targeted drugs that have developed that inhibit molecules in this pathway. There's C3 molecules and C5 molecules, all part of the immune system. These drugs were tested in phase 3 clinical trials and approved by the FDA in 2023.
Perfect. And can you kind of walk us through those approved treatments, which are named Syfovre and Izervay, and how they work to slow the progression of GA?
Sure. So Syfovre, it's that's the brand name. Its generic name is pegcetacoplan, and Izervay, which has a brand name of Izervay and a generic name of avacincaptad-pegol, just so you guys are all aware. So like I said, they're both basically complement inhibitors, meaning that they inhibit molecules in the inflammatory pathway, the complement pathway. So Syfovre is a C3 inhibitor, so it blocks all downstream complement activation. The Izervay is a C5 inhibitor, so it blocks formation of C5a and C5b and this membrane attack complex. Both these approved treatments slow the progression of geographic atrophy or death of the retinal cells, like you discussed, but they do not restore lost tissue. So in summary, that was very complicated, but basically both of these drugs just inhibit molecules in the inflammatory pathway.
Perfect. Thanks. Great. That's awesome. And so, kind of as an additional question that might sound a little silly, but if Syfovre and Izervay target different pathways that help slow geographic atrophy, is it possible to use both drugs simultaneously to slow down GA?
Thank you, Jenny. That is a great question as well, and it's something that many people wonder. But currently, using Syfovre and Izervay together is not recommended because there's no clinical studies of combination therapy. The pivot trials that we have, which are OAKS and Derby for Syfovre and the Gather 1 and 2 for Izervay, these pivot trials have tested each drug alone, but they did not study the simultaneous inhibition of C3 and the C5. And so actually, in fact, there could be some safety issues when we target both of these molecules in the same inflammatory pathway. So with simultaneous use of both of these drugs, there's going to be a deeper blockade at this complement inflammatory pathway in the body, and that might not necessarily be better, and actually can lower your immune system and inflammatory response so much so that it can be dangerous. So currently, it's best just to pick one agent, monitor carefully, and treat consistently to slow geographic atrophy growth. Switching drugs, however, from one to another could be considered if, you have a safety issue with one drug, or, there's logistic preferences, such as insurance coverage or frequency of dosing, but simultaneous dual therapy is not evidence-based at this time.
Perfect. Thank you so much for that explanation. And then continuing on, what should people expect during treatment, and how often are injections needed, and what is the procedure like for both of these drugs?
Okay, so basically, in terms of what people should expect during treatments, so the Syfovre intravitreal injections, they occur every month or every 2 months, and then Izervay injections occur every month. The FDA had this prior 12-month duration limit that it removed for Izervay in February 2025. But there have been some studies that have explored every other month injections for Izervay as well. But the current US label for Izervay is monthly, whereas again, Syfovre is every month or every 2 months. The procedure for an intravitreal injection is topical anesthetic done by your ophthalmologist. Then we put some betadine to basically clear the bacteria. We do the quick injection of your eyes at a specific location that we mark, and then we quickly check your vision or your eye pressure, and then go over some return precautions for you.
Great. That's an awesome explanation of the procedures. In terms of the two drugs itself, there is some long-term data that has been recently revealed about the effectiveness of these treatments in preserving vision and retinal structure. Could you kind of describe a little bit about those studies?
Absolutely. So basically, in terms of the long-term data about the effectiveness of these treatments, so for Syfovre, there's a trial called the OAKS trial, and that showed that Syfovre slowed the geographic atrophy at 12 months. And then there's an OAKS and Derby trials that have showed that Syfovre slowed geographic atrophy growth at 24 months. And then there's a third one, an open label Gale study that showed an increasing effect with continued treatment into years 3 and 4 with emerging functional benefits. So, and I'll explain sort of what that means more simply. And for Izervay, there was a Gather-2 trial that showed ongoing slowing of progression of geographic atrophy through 2 years with an increased treatment effect versus 1 year with consistent safety results. So in fact, for Izervay, based on the results of this study, the FDA removed the duration cap for the US label in February 2025, so that the label is now unrestricted for duration. But basically, the studies have shown there's specific trial for Syfovre and Izervay, and they've shown that, when you treat these patients for longer, that versus the controls, which is just the sham injection, there's even more slowing of progression of the geographic atrophy.
That's incredible. Thank you so much for summarizing the long-term data for both of those drug treatments. And so the next question that I have, Dr. Fard, is why is sustained treatment important in managing geographic atrophy, even if patients don't notice any immediate changes in their vision?
So the geographic atrophy and age-related macular degeneration, Jimmy, grows steadily. And the long-term data shows an increased effect with continued long-term injections. So the goal is to delay retinal tissue loss, but it may take 1 to 2 years or more to see a big effect compared to the controls.
Lovely. And then how does ongoing therapy help protect retinal tissue and support daily visual function over time?
The ongoing therapy will help protect the retinal tissue and daily functioning, as the treatments will hopefully lead to slower lesion expansion, thereby preserving more functional retinal tissue for a longer time. In studies, Syfovre has shown a slower loss of central light sensitivity and fewer new blind spots and pools. Izervay analyses have suggested lower rates of categorical vision loss, both compared to controls, suggesting slower rates of progressive vision loss in treated eyes than controls.
Awesome. That's a great explanation. And are there any measurable differences in outcomes between patients who begin treatment early versus those who wait?
That's a great question as well, Jimmy. But retrospective and follow-up analyses have shown that earlier and continuous therapy preserves more retinal tissue than a delayed start, and that treatment effect often strengthens after the first year for both Syfovre and Izervay. Also, it can be important to note that more retinal tissue may be saved if the patient starts his injections when the lesions are smaller and the fovea is not involved, which are typical of earlier stages of disease.
Perfect. So again, it is really important to make sure that you go to your healthcare provider to check for your eyes to make sure that you do not have any developing signs of AMD or geographic atrophy, and that these specific treatments, if you've done early, can really help preserve vision.
Exactly. Yeah.
And so the next question that I have that I think is really important for people on the call is, how do you address concerns about the side effects or treatment burden with these specific drugs?
Okay, thank you, Jimmy. And sort of to go back on your last point, it's exactly what you said, that this age-related macular degeneration process is slowly, progressing. And if you start before these lesions affect the center and cause that scar tissue or lead to that, death of cells in the center of your vision, then you can preserve more of those cells for a longer period and use that youthful vision. But in terms of side effects or treatment burden, basically common side effects of injections of Syfovre and Izervay, similar to any injections, are sort of the subconjunctival hemorrhage, which is just basically the bruise at the white part of your eye, floaters, transient eye pressure increases, and mild discomfort. But with these injections in particular, there is a concern about increased rates of conversion from dry to wet age-related macular degeneration, with label reported data at 2 years being for Syfovre about 12% conversion to wet AMD with every month and 7% for every 2-month injections compared to 3% in controls. And for Izervay, The conversion to wet age-related macular degeneration has been about 7% 1 year and 11.6% at 2 years with monthly injections compared to 9% in controls. So if, you do have that conversion to the wet age-related macular degeneration, your injections will stop being Syfovre and Izervay and will be anti-VEGF injections, which are currently the standard of care. There are other rare but serious side effects as well, such as, a post-injection infection that can happen with any injection. But the Syfovre label also includes a very rare 0.01% per injection of this infection. So it is very rare to have these infections after an injection. But there are serious warnings of retinal vasculitis, which were often occlusive and all followed the first injection within 2 to 3 weeks of injection with the Syfovre. So to reduce the risk of injection, the ophthalmologist will proceed with the sterile technique and close follow-up and warn the patient about return precautions, especially in the first 2 to 3 weeks after an injection. And then to decrease treatment burden, which means like coming frequently for these injections, patients can discuss these injections every 2 months instead of monthly.
Great. That's an awesome explanation about the different side effects about these two different treatments, which again, Syfovre, which is spelled Syfovre, and then Izervay, which is Izervay. And as a follow-up question, Dr. Fard, for those who experience mild discomfort in their eye from these injections, how long does that usually last if that happens?
Mild discomfort in their eyes, I guess it would depend on like what is the cause, but typically patients might have a little bit of soreness after the injection, a little bit of irritation because the betadine, which is the antiseptic, that will last just that day and resolve by the next day in almost all cases. You can use some artificial tears the next day to help you as well. But if you are having any serious side effects, so that being, worsening vision, flashes, floaters, red eye, lots of pain that persists beyond a day, you need to see your ophthalmologist. But that typical like soreness usually only lasts 1 day.
Perfect. Thank you so much for that explanation. What advice do you have to give to patients who are hesitant to start this treatment because they feel their vision is still okay? And I know we've talked a little bit before about the earlier the better, but just maybe as a reemphasis.
Absolutely. Thank you. The geographic atrophy does often spare the fovea, and the fovea is the center of the macula and the center of the retina, which allows for central vision. Early on, the geographic atrophy spares the fovea, but once the atrophy or the death of these cells reaches the central fixation, then vision loss is irreversible because it's sort of like loss of cells and we can't regenerate the cells. So the goal of these injections is to delay the progression of the disease process. So to allow more time for the functional vision, that central vision for hobbies that you have, like taking care of your children or grandchildren and for driving.
Perfect. Yeah. So just like what Dr. Fard said, it's really important to go see your eye doctor to make sure that you're not developing signs of AMD. And so you're able to do those hobbies you enjoy doing or seeing your family and loved ones. Another question that I have with you, Dr. Fard, is there any other or any promising therapies or technologies on the horizon that could further improve outcomes for geographic atrophy patients?
Okay, so thank you for asking that. So there are new routes and targets, including subcutaneous complement inhibition, which is called the Sienna trial, and oral candidates as well instead of injections, which is named the Jade trial. Both of these trials are available actually at my practice, Illinois Retina Associates, but they both do require to follow up on site monthly. The Sienna trial, which is the subcutaneous complement inhibition, is a phase 3 trial. Patients must have non-central geographic atrophy that your ophthalmologist can diagnose with an exam and imaging. And the treatment includes basically subcutaneous injections of these different targeting agents versus a control. These are therapeutic agents that also target complement inhibition. So basically, it's sort of like an injection in your skin, that is going to target the same pathway, but it's not an injection of your eye. And then we have the Jade trial as well, which is a phase 2 trial. It has an oral target. And the oral target now, so it's an oral agent that you basically take by mouth. It's a phospholipid modulator, and it works by reducing inflammation by antagonizing or basically blocking certain receptors on immune cells and eye tissue. And this allows for decreased inflammation and preserved vascular function in the vessels of your retina. So those are two of the trials that we have ongoing at Illinois Retina Associates that you guys can ask about. But there are also other emerging cell and gene therapies like RPE cell therapies as well.
Wow, that's incredible, Dr. Fard, that instead of getting, monthly or 2-month injections, that you can take something that's either oral or through subcutaneous or through the skin in order to help with someone's geographic atrophy. That's really cool.
Absolutely.
Yeah. And then how do you see the standard of care for geographic atrophy evolving in the next few years?
So thank you, Jimmy. This is obviously like a hot topic for many ophthalmologists and researchers and patients. But over the next few years, there will likely be earlier detection of geographic atrophy with our retinal imaging. And there's also going to be likely more individualized dosing regimens with more long-term data with improved safety profiles of the current therapies available. So, the studies that I talked about are following patients up to like 3 to 4 years with Syfovre. But maybe at that time, we'll have longer term data. We'll know more about like safety. We can maybe individualize things more on the specific like patients, have more, agents available, maybe even have the oral or the subcutaneous skin injections that we talked about. So all of those agents.
That's awesome. Yeah, that's great that there's an evolving standard of care for geographic atrophy for patients out there that patients can look forward to. And so I think we have time for some additional listener questions, if that is okay with you, Dr. Fard. One of the questions that we received from one of the listeners was, um, and this may go on a little bit about talking about retinal scans. So how do I know my treatment is working? What can you see in those retinal scans that tells us that my treatment is working?
So basically, Jamie, that's a great question. At this time, so geographic atrophy related to age-related macular degeneration in itself is slowly progressive, but it does, progress in patients. And these drugs slow the progression of the geographic atrophy, like we talked about, right? So there's no way in an individual to say, this drug is definitely working or not. However, in our trials, we've seen that, compared to controls not getting these Syfovre and Izervay injections, the rate of progression of the death of the retinal tissue is faster than those getting treated, especially with longer duration of therapy. So in an individual, so a patient getting these injections, we will be able to see that with time, maybe a year, 2 years, with these injections every month or every 2 months, that the age-related macular degeneration is slowly progressing, very slowly, but we can't say, like this drug is the reason or the patient's, there's no way in an individual right now to say, this drug is definitely working. All that we can see is that, this eye is very slowly progressing in its age-related macular degeneration, and this may be likely to the drug given the studies that we have based on these drugs.
Yeah, great. Thanks so much for that explanation, Dr. Fard. Another question that we had was we talked about those two different pathways that lead to geographic atrophy. And so one listener asked, how do you know if C3 or C5 complement pathway is my issue? Could we be treating C3 when I'm actually impacted by C5 complement pathway?
So basically, it's the causes of age-related macular degeneration and geographic atrophy are very complicated and multifactorial, right? And, what that means is that basically somebody who has age-related macular degeneration, like the dry stage, has it because of many things, right? There's some like genetics, there's some inflammation, that's the complement pathway in the eye. There's some, like smoking, healthy diet, maybe that's all related to the inflammation. But basically, the complement pathway has different targets like C3 and C5, and in an individual, basically, that the studies have shown both C3 and C5 are involved in the immune process and the age-related macular degeneration. These drugs are targeting different, the C3 or the C5, but in an individual, both the C3 and the C5 are involved in age-related macular degeneration. And it just the drugs are targeting different points in the same pathway, leading to the same results.
Perfect. Thank you so much for that explanation. We have two more listener questions. So one question that we had was that can you have wet AMD and geographic atrophy in the same eye at the same time? And if so, which is more important to treat?
That's actually such a great question. So geographic atrophy means death of cell layers, right? We can see it basically clinically when we look at your eyes. We can see it on imaging and confirm it with imaging. It gives us a better look with something called OCT and also fundus autofluorescence. You can have geographic atrophy with the wet age-related macular degeneration because geographic atrophy in itself just means, death of certain layers in your retina and so forth, okay? However, if you have the geographic atrophy without any signs of the wet age-related macular degeneration, so without any swelling of your retina, without any bleeding of your retina, that is just called advanced dry age-related macular degeneration, and you're a candidate for the Syfovre and the Izervay. Now, on the other hand, if you have the geographic atrophy, which is death of those cell layers, now with swelling of your retina that we can see on imaging, with basically, abnormal blood vessels, with bleeding, that's called wet age-related macular degeneration. And at that point, the standard of care is going to be another type of injection called anti-VEGF injections. So you might have heard of injections like Avastin, Eylea, Lucentis, Vabysmo. Those would be the ones for the wet. So in summary, geographic atrophy itself just means death of cell layers. If you have it without any of the swelling and without any of the hemorrhage, it's advanced dry AMD, and you can get Syfovre and Izervay. And if you have it with the swelling and the bleeding, then it's called wet AMD, and you need the anti-VEGF injections like Eylea or Avastin. And your ophthalmologist can diagnose that correctly and guide you to the standard of care.
Perfect. Thank you so much for that summary and explanation of that question, Dr. Fard. That was really great. And a final question that we had was a listener wanted to ask, has corrected vision been demonstrated at all, or just reduced lesions when taking either Izervay or Syfovre?
So that's a great question too, and something to emphasize, and something that we will talk about in our key points. But so Syfovre and Izervay do not reverse vision loss that's already happened, and that's one of the reasons that Jimmy and I were discussing with our group today, our audience today, that you want to get into an ophthalmologist earlier and possibly get these treatments earlier, because these treatments of Syfovre and Izervay, they can't reverse the tissue loss that's already been there. They can only further slow the progression of your age-related macular degeneration. So they're not going to correct your vision, but they're going to basically slow down the vision loss that you would otherwise be having with the age-related macular degeneration.
Perfect. Thank you so much, Dr. Fard. Yes, and again, just to reiterate, like what Dr. Fard said, it's really important to go see your eye doctor to make sure that you aren't developing any signs of AMD. So you can make sure that you can see your loved ones, your family and friends, and do all those hobbies that you enjoy doing. So great. And so I just want to thank Dr. Fard. Thank you so much for all the information you shared with us today. And so Dr. Fard, before we close, do you have any message that you would like to share with patients and families navigating a new geographic atrophy diagnosis?
Yes, absolutely. And I just want to thank you also for all the questions, Jimmy, and thank you to our listeners for taking the time out of their day. And also reiterate your point of, seeing your ophthalmologist as soon as possible and inquiring about these medicines and getting treatment earlier than later to slow your geographic atrophy. But finally, key points for a new geographic atrophy diagnosis are that one, this dry age-related macular degeneration is a manageable disease. And although the Syfovre and Izervay injections cannot reverse vision loss and therefore cannot improve vision, like we were saying, they can lower the risk of large visual acuity losses over time by possibly slowing the progression of disease, which has been shown in studies over a year, 2 years, and then even more effective longer. And that patients and families should continue consistent ophthalmological follow-up to monitor for side effects and adverse events and pay particular attention to their lifestyle. So that includes the ARES2 supplements if you had intermediate dry age-related macular degeneration in the other eye, that your ophthalmologist can help diagnose. A healthy diet is also encouraged with green leafy vegetables and omega-3 fatty acids, avoidance of UV exposure, so always wearing your sunglasses, smoking cessation, and note that treatment can help slow progression rates of age-related macular degeneration.
Awesome. Great final advice, Dr. Fard. Well, thank you again for joining us today. Our next Macular Chat will be on Wednesday, October 29th. This concludes today's Macular Chat.
The information provided in this recording is a public service of BrightFocus Foundation and is not intended to constitute medical advice. Please consult your physician for personalized medical, dietary, and/or exercise advice. Any medications or supplements should only be taken under medical supervision. BrightFocus Foundation does not endorse any medical products or therapies.